Good morning. Thank you for inviting me to speak. I do have some disclosures. I work for Biogen as a consultant in the research. I'm also on staff here at the Packard Children's Hospital. I do both inpatient and outpatient care, and I'm also involved with the neuromuscular clinic twice a week. Some of my goals here for today is I'm going to review the standards of care for rehabilitation with children with SMA. I'm going to identify strategies for contracture management and also think about both contractures and function and also goal setting. I'm going to discuss treatment options for SMA and all the different functional levels. I also want to thank you as a group, physical therapists, neurologists, and such. The physical therapists here, especially the occupational therapists and speech language pathologists in the county CCS system, in early intervention, you guys meet with the families week in, week out. You guys engage with the families week in, week out. That's the key to a lot of the rehabilitation. Engagement, engagement, engagement. If you can get these families and patients engaged in the process, bought into the process, the better the outcomes. I'm going to talk about where we came from. About a dozen years ago, we didn't really have a uniform way to treat these children. We didn't have a drug out there. Dr. Ching Wang here got together a bunch of neurologists and therapists to talk about what is the standard of care. And loosely, we talked about, as a group, what would be our recommendations for that standard of care. Basically, aerobic exercise, range of motion, function, but there was no specific recommendation for exercise at that point. At the same time, where we are, we're collecting this natural history data, trying to define what does a child look like. A sitter, a non-sitter, a walker, what do they look like? And we were using these functional outcome measures. For the younger children, the CHOP and 10. For the sitter, Hammersmith, and the walker also for the Hammersmith. And with the wheelchair, older child, the ROM. As this patient population changed, we are making these observations. And we're seeing that we have a new phenotype. We can't expect the old observations to apply here. What you need to think about when you're in your clinic is, how old is this child? When was this child diagnosed? And is this child being treated by a drug? And at what time were they diagnosed? At what age? And what time did they get treated? And where is the progression? Now, we know the progression without drug. We've been studying that. We have natural history on that. What the drug manufacturers and researchers do is they look at the natural history and they compare it to applying the drug. There's ongoing research, raising levels of SMN, as you heard, gene therapy, targeting muscle. So it's a very exciting time right now. It's a very shifting time right now, a shifting phenotype. We may understand that this child may look like SMA, but to me, today, the child with SMA doesn't look like anything like what I saw 5 years ago. So you need to really think and dig deep to think about, how do I plan for this child and how to interact with this child. In 2018, we got together again to update the standards of care. And to make note that this standard of care update was before the new treatments. We got together as a group. There's two parts to it. Part one talks through the rehabilitation and orthopedic care and nutritional care. And it was a multidisciplinary approach. We got together and ranked all the different areas of what we thought was important in the treatment of children of SMA. That included stretching, bracing, exercise, and post-operative care. So I'm going to go into that in a little bit. This picture is very common to you. You know, it's this kind of multidisciplinary team model. And we think about it as healthcare practitioners, as the patient being in the middle, the family being around the patient, the coordinator around that patient, and then on the spokes of the wheel, you have all the different caretakers. And as you saw yesterday with the mom on the stage, there could be a ton of caregivers around there. And to have that coordinator and that mom to coordinate all that is difficult. But we try to work as a multidisciplinary approach in clinic. Here at Stanford, we have a PT/OT speech pathologist, nutritionist, the neurologist, a social worker. We try to engage in the process, including with pulmonology and orthopedics, to try to set up a plan that the family can carry out day to day, to also adapt to the therapy program. What's behind this, and what you think about, what that we don't always think about, is what the parent thinks about all this. There's a study out in the Dutch study in the Netherlands that looked at caregiver support. They looked at what is the well-being and the caregiver well-being of children and adults with SMA. They found a high level of burden for working with children. 73% of the moms out there, of 48 patients, found that there was a high level of burden taking care of these patients. In adults, it was even higher. 88% found it to be high burden. With that, high burden showed that there was a lower well-being in the moms, and also higher levels of depression, higher levels of anxiety. Depression was about 17%. Anxiety was about 22%. So it's really important to me to think about, am I engaging not just the child and all of the range of motion issues, the strength issues, the standard of care, but am I engaging the parent? What will make that parent's care burden easier so they can engage in social life, so that child can engage in social life? That's essentially what we want to do. Maximize both parents, maximize the child in both functional levels as well as life engagement. I'm going to go into management of limb contractures. This is an article in 2013, a little bit older, by Slapke. In general, you want to think about prevention. And you guys are the best out of this. You guys work with range of motion, bracing. Contractures in this group, especially with younger children, are inevitable. Type 1s, type 2s, you will have contractures. Very notably in the upper extremity, finger and hand contractures and wrist contractures. Very notably in the lower extremities, hamstring, heel cord contractures, and hip flexion contractures. These contractures can be managed, and they're managed basically all of your standard things: positioning of upper and lower extremity, daily passive stretching, walking, positioning of limbs, and prevention in splinting. We know children and adults who walk have less contractures. Children and adults who are active, more active, have less contractures. We know children who are immobile or wheelchair-bound have more contractures. We need to engage in this process and help decide what are things that we could do to provide effective care for these children. Now, this is a generalized recommendation, and this was a paper that was sent out to the world to make generalized recommendations. And the idea with stretching was basically to do it, you hold it for a minimum of time, 3 times per week, 5 times per day, 5 times per week or daily. My recommendation in clinic for me personally is to use actually braces. It's much more effective to use hand braces and ankle braces for 6 to 8 hours a day. Within our paper, the recommendation is to hold this stretch, to do stretching daily, for at least holding this stretch for 30 seconds, and to do it 3 to 5 times per week. So managing of limb contractures for the older adult, we recommend periods of standing and walking. Standing and walking of 30 to 60 minutes per day. In a lot of children with SMA, as they develop, they may not stand, they may not walk. We recommend standers for the type 1 and type 2. For the children who have poor head control or head control less than fair, we recommend a supine stander so that they can recline back and to be able to support their head. and or they can provide TLSOs and TLSOs with additional head support. Hips can be positioned in an abducted position, 30 to 60 degrees, to allow for some weight bearing through the acetabular. Use also AFOs and standers. A lot of these kids are also weak in their ankles. In children that are developing that are showing some active bearing weight, and what I usually typically do in around 10, 12 months is I would put them in a vertical position, see if they could bear some weight either on the free floor or up against a table or a bed, and see if they can put weight into their legs. If they are able to have head control, trunk control, we try to do AFOs or KFOs or even knee immobilizer or no-nos to put them in that upright position. We also try to use gait trainers and walkers for the type 3s. With management of limb contractures, in the lower extremities, knees are the most common. Tightness is in hamstrings, and we look at the popliteal angle, and that's followed by the hips and the ankles. In the upper extremities, again, shoulders are the most common, followed by the elbows and the wrists. You also want to think about knee and elbow motion in the child that has hyperextensibility. It's really important to look at elbow hyperextensibility, especially the child who has type 2, who uses their arms to prop and also transition. We want to protect those joints, especially as they get older and they rely on these joints to move. We use AFOs to slow the contracture development. Again, we try to recommend full-time at night bilateral AFOs. If it becomes problematic, I tell them to alternate right and left sides. We usually position the AFO at a 90-degree or ankle neutral. If they have COFOs, we put the knees into full extension for standing and ambulation. The bracing recommendation, again, this is a recommendation that was placed out to the whole kind of world, is to do standing 3 to 5 times a day, 3 to 5 times per week to 30 to 60 minutes, 5 to 7 times per week. My recommendation, again, is daily standing and walking for at least an hour every day. Upper limb contractures are very common. Can be problematic, especially in the elbows, very common. It becomes problematic when you have contractures above 30 degrees, and that precludes them from reaching forward, reaching overhead, as well as using gait aids and transfers from wheelchair and out of wheelchair. Contractures of the elbow, when they get to up to 60, it reduces the reach forward as well as the reach up to do feeding and also bathing. Other common contractures that we sometimes forget about is forearm pronation and supination. We always want to check elbow supination to look if there's any contractures there. Also, contractures in wrist flexion and an ulnar deviation. You occupational therapists are probably better than I am about management of wrist and the hand to try to maintain that functional motor skills, both in a passive stretch as well as an active functional splint. So they can have a nighttime splint and also a functional daytime splint to promote not just finger positioning, but finger and hand use. Again, one thing we move forward is to talk about neck contractures. As these children are starting to move, type 1s, type 2s, before it used to be about, be able to promote positioning. Now we're trying to promote function. And what we're seeing is a lot more torticollis, a lot more atypical head development. So really think about your cervical positioning, think about your cervical stretching. I'm going to go into management of scoliosis. We regularly see scoliosis, especially in the child that does not walk. The weaker children, the majority of them will have either a C-shaped curve or an S-shaped curve. Approximately about 90% of them who do not walk will have scoliosis. The children that have a lesser degree of scoliosis are the ones that are stronger. The child that walks, the child that stands have less scoliosis. It can occur as early as 9 months. At that point, we typically do a spinal x-ray. That occurs every year. These curves can progress very rapidly, so it's very important that we monitor them on a yearly basis. As well as hand in hand with trunk weakness comes also vital capacity weakness, as well as structural deformities that will impair breathing. In scoliosis, in SMA, curve compression can happen about 8 degrees per year. So especially around the childhood, school-age child into adolescent, that curve can change pretty rapidly. We order TLSOs all the time. They don't stop progression of the scoliosis. They do improve stability. They also improve positioning. The question I get a lot is, what's the right type of TLSO? And it's really difficult. You know, we have to provide a functional position as well as not to impair the transitions from supine to sit, as well as transitions from bed to wheelchair. What can occur is sometimes I would recommend a TLSO that they wear to school, that they're in the chair for 6 hours a day, but when they come home and they play around on the floor, they take off their TLSO so they can transition in from supine to sit, or from their chair to the floor to the bed or to the couch. Just remember with the TLSOs, you want to do a cutout in the stomach so you can allow for abdominal movement, and also a G-tube. We use the TLSO for also respiration for positioning, so that can get more an upright position. This is kind of the matrix that was in that paper. We do a clinical exam in the office for a sitter. I just look at their spine from the posterior and from the lateral position. I have them either transition forward to see if their spine is flexible or inflexible. Once they see a curve, have them do a spinal x-ray. This occurs especially for any child that can stand and even walk. We still do a clinical exam. If it's less than 15 degrees, we just monitor. I typically don't recommend any TLSOs. For some of the younger kids that have no curve, we do soft onesies that can be dynamic. The one thing you have to be careful about is fatigue. So you can certainly use those dynamic onesies and binders and such to help position the trunk. If the curve is anywhere 15 to or 20, 30 degrees, we recommend bracing. Bracing in the position of the upright position. And then as they progress for greater than 50 degrees, we recommend surgery. In immature patients, younger patients, we recommend growing rods, and in the more mature patients, they do spinal fusions. Again, bracing in this group is all palliative. We can't stop the curve. What you can do is strengthen them. What you can do is put them in standards. What you can do is promote walking. We know the kids that are stronger have less of a curve. So the management of scoliosis, again, non-operative considerations with a TLSO, positioning your wheelchair, all you guys know are better at it probably than I am. But you also need to think about is pain management. Always ask your patients about pain. You know, do they have pain sitting, prolonged sitting? Think about skin management. Think about having the parents check their skin. Also thinking about weight shifts. This is one of the biggest kind of talks I have with all of my patients who are ambulatory and who are wheelchair bound, is because they're students, because they sit and play games, they are sitting for at least 6 to 8 hours a day. I recommend weight shifts for every 15 to 20 minutes, so about 2 to 4 times an hour, where they're either shifting their weight or getting out of their chair into a stander or just out of their chair. We try to help them maintain range of motion of the hips and knees, especially the hip flexors, maintain their core strength, We promote standing and ambulation and use of walkers, gait trainers to get them in the upright position. What's really important for this group that are thinking about a posterior spine fusion, we need to think about their preoperative status in standing and walking and wheelchair position and their postoperative status. Really think about planning ahead and making those changes on a time need basis, because we know standers, walkers, wheelchairs may take 3 months, may take 6 months to make those adaptations. Again, surgical management is based on curve progression, typically older than 10 years, larger than 40 to 50 degrees. The thing to think about with post-surgical management is we want to get these children up. And in the hospital, we try to get these children up at latest post-op day 1. We try to get them back to their previous level of function as soon as they're discharged from the hospital. We recommend early physical therapy post-operative management of a child with a posterior spinal fusion. Management of subluxation and hip dislocation in children with SMA, especially type 2, about 30 to 40% will have some type of subluxation hip dislocation. May not be painful. Always check their hip flexor range. That's really important. Dislocation can occur as well. It occurs about 30% of the time, and about 20% of the time of type 3 patients who are ambulatory. We typically have these hips corrected if they're ambulatory. The incidence of reoccurrence happens just as often as you don't do surgery. So program planning for management of a dislocated hip is challenging. We're finding that we're talking about it more, especially children who are just sitting, because we have the potential. We have the potential now of getting them in standing and possibly walking. So really think of what the child is doing now and what the child is headed towards. There's limited data in the effectiveness of surgery in this group, but I think a lot of these neurologists and orthopedists and physical therapists are really looking at one of these areas. Again, post-op management, we look at modifications to the wheelchair, sitting height, transfers, bathing, toileting, all these things we think about with any post-operative management, but we would like to do it post-op day 1, if not post-op day 0. I'm going to go into treatment of the different levels of SMA. Non-sitters, sitters, walkers. We'll talk about interventions. We'll talk about goal management. And again, really think about how old were they diagnosed? How old are they now? How old, when did they get started treatment? We have a generalized idea if we get treated earlier, the outcomes are better. It's generalized. But I really want you to think about all these standard measures that we're using. Use these standard measures to identify where are they functionally lacking, what areas they need to kind of get to the next functional areas. I find that in the non-sitters, I'm getting them up more upright. As you know, the type that are non-sitters are profound weakness, limited motion against gravity, limited trunk control, like limited head control. They spend a lot of time in supine. They have a significant fatigue with any activity, both extremity activity or even changing their positions. We try to support them in play in their upper extremities and lower extremities. A lot of times we use like the slings and springs. We try to support their arms or their legs, or even in the agial arms, where we support their arms and legs to provide friction-free movement. Now, with these children, it's really important to think about their choice of equipment. A lot of families like to go with the minimalist. What is the easiest, the lightest, I can get in and out of the car? That may be helpful, but we want to also maximize the function. Increase engagement with the family with this process so you can maximize the function in both the upright position and the fully flat position in this age group. You want to monitor the amount of work they're doing, the work of breathing, their amount of fatigue, their oxygen saturation with this age group. Here's a picture about the slings that we use, and or angel arms, where you can offset the weight of the arm or leg. The idea, again, is you're supporting the limb weight and you're offsetting so they don't have friction to move, and you're doing gravity eliminated or against gravity motions. I typically also use TheraBand, give them a little bit of a stretch to be able to move. Do adaptive strollers, again, making sure that they can recline fully. Car beds, Hope car beds, so they can be transported safely. The thing to think about in non-sitters, and the thing that we've started doing more and more of, is can this child tolerate in the upright position? How do you measure that? And again, you can measure that by the amount of times they do it during the day, how frequently, the frequency, the amount of time they do it, 15 minutes, the degree, the position they're in sitting or in standing, and the response, their oxygen saturation, or the level of awareness. Also, monitor their pain. In this age group, it's challenging because the younger child are not vocal. I use what's called the FLACC scale, F-L-A-C-C, and it's basically a scale that it's an observational scale. It's a checklist that you can monitor their pain, and it's a 10-point scale. I don't stray away from sitting these children. I don't stray away from standing these children, but you have to think about safety. Going back. Now we're going to go into sitters. As these children get stronger, we see these children are sitters, and they still have weakness. They have weakness in their legs, they have weakness in their shoulders, in their trunk. They have a lot of contractures and respiratory dysfunction. They have scoliosis. They have limited endurance. They require assistance for ADLs. The typical thing that we try to do is monitor contractures. Bracing, stretching, all the things we've done for the non-sitters, we do for the sitters, with the appropriateness of the upright positioning. Think about strengthening and exercise in the upright position. Also, think about that in the transition position. What positions they need to do, what range of motion, what strength they need to transition from supine to sit, or even sitting, or to get into the standing position. The equipment includes any seating that you can do, or any mobility devices, both in a power chair and or a floor mobility device. We have assistive technology to be able to engage with their environment and also engage at school. We try to recommend PowerMobility at anywhere typically from the age of 2 to the age of 3. We try to keep their AFOs and their KFOs as lightweight as possible so they can try to improve their mobility. Again, we also try to do mobile arm supports and augmentative slings to improve motion. Again, these are just basic braces that you all know: SMOs, AFOs, KFOs. Again, you want to think about, if the child is in a stander, always use an AFO just to support that ankle, to be able to do weight-bearing positions so that they don't overpronate their ankle positions. The recommendation, an average of an hour a day or 7.5 hours per week to maintain bone density, stretching their muscles, and overall GI and respiratory functions. It is also important to kind of talk to your school, see if they can also do some standing at school and have access to a stander school so that they can have a position outside of their wheelchair. Also think about your wheelchairs and strollers for this age group as well. These are mainly used when they're younger as a primary chair, and as they get older, they use power chairs as well. There are a couple slides on PowerMobility. One thing I want you to, again, think about as in this paper, this is a really older paper that looked at all these neuromuscular disorders, and they found that children from anywhere from 20 months to 37 months were able to attain the goal of independent wheelchair power mobility. So when you think this child needs something to get them moving with their environment and they're old enough to understand simple directions and able to manipulate a joystick, get them into a power mobility. So a child as young as 24 months may be able to be evaluated for that. And in case study documents, they found that it takes them about 6 weeks to be able to drive a power chair independently. So we go on further into type 3 walkers. Walking try to maximize their functional independence both at home and at school. We use wheelchairs for long distances and also for energy conservation. Sometimes they use their wheelchairs to get to school, get to their classroom. They get out of their chairs, they go into their classroom walking, they go play walking, but they go from class to class into the wheelchairs or from the school to home into the wheelchairs. Always think about contracture management. For the walkers, again, hamstrings, hip flexors, heel cords, for the lower extremities. And sometimes I forget for the walkers is look at the TFL and check your Ober test to see if there's any tightness there. We always recommend regular exercise, contracture management, swimming, horseback riding, adaptive sports. All these things are engagement. You really have to engage. What does the child, what does the family like to do? And the most common question I have when I have a child and family in clinic is, what's the exercise? What's the best exercise? And my answer to them is, what exercise are you willing to do? What exercise do you want to do? What do you really want to do? Because if I just give them like a static exercise, they may do it for a month, and then 12 months later, 6 months later, it's not there. But they're engaged in an activity, wheelchair soccer, playing tag with their friend, playing Wii, standing. They'll be doing that weeks on end, months on end. So engaging in that activity is going to be very important. Some of the things we think about with walkers that we need to also think about is weight management, making sure that they're fit, make sure they have active aerobic exercise. As they get older, too, is how they can keep up with their friends, any modifications to their house or to their schools, getting key access to the elevators at schools so they can get up to the 3rd floor classroom, and also driver's education so they can be driving when they're ready. Here's another paper by Sally here. She looked at early power mobility. And in here, as long as they have basic cause and effect, basically if they can do use of cause and effect in about 3 months or 4 months, they were able to have independence and directional control of the power mobility. It took an average of, in here, 12 months from initial evaluation to delivery of a wheelchair at home. So that's a long time, right? If we think, okay, this child is 2 years old, they may not get their power wheelchair until they're 3 years old. A lot of development, a lot of changes might have happened already. But again, really think ahead. Think ahead when you are doing these plannings. Again, recommend prescribing a power mobility, early mobility before the age of 2, getting that process started. Before I go into exercise, I have a little bit of time. I'll talk about goal setting. In the early child, type 1, again, I talked about upright positioning, time, frequency, also the ability to reach, both with a supported position and an unsupported position, too. How much movement, active range, you can visually score their active range in kind of observational range of motion. In the type 2 is, can they maintain that position? How long are they sitting unsupported? Can they transition in and out of prone, in and out of sitting, in and out of standing, sit to stand, stand to sit? All those functional positions are important because if they don't get into those functional positions by themselves, they won't get into the functional positions frequently. The idea is frequency. How often are they getting into those positions? And in the older adult, functional goal setting mainly is to maintain or to maximize their engagement into the school. And my question to the older adolescent is, what are you doing outside of school? What are you doing in exercise? What are you doing to keep up with your friends? And if the idea is, oh, I go to my friend's house, which is down the block, to play video games, and I need to do that. So we need to figure out how they can get through their day, how they have as much energy to get to their friend's house and to sit and do their homework at home, do their chores, get bathed, and get to their friend's house. All those things, goal setting is important. And you can find the barriers all along the way. Barriers of, maybe there's a curb there or a one step in and out of the house that makes the most difficult thing for them to do. So it may be a step. It may be their balance on an uneven surface. Really think about what are the barriers for them to be the most functional they want to be. Not what I want to be, what they want to be. So I'll talk about exercise. This is that question I get all the time. What's the best exercise for me? And how much is it important? How much is it appropriate? And in all the literature, it's really unclear. Most of the evidence is all in animal models, but the research points to a moderate intensity, low resistance exercise. It could be at least not harmful and marginally beneficial. Jackie will actually spend her whole time talking about exercise. We made the recommendation in our standard of care to do exercise for at least 30 minutes, 2 to 3 times a week, optimally 3 to 5 times a week. My recommendation as a therapist in our clinic, I try to get them exercising at least an hour a day, multiple times a day. And it could be broken up. And the idea is that they do it frequently and often, every single day. For the children who are in wheelchairs and who are ambulatory, I try to get them outside. The more they're engaged in the process, the more they're able to do more frequently. I'm going to go into, let me go back. One thing to think about with strengthening exercise is strengthening okay? Is it safe? It's safe if they have the ability to do the manual muscle test of FAIR. If they have FAIR, you can do strengthening, both eccentric and concentric exercise, as well as resistance exercise, as long as they have fair amount of strength. If they have less than FAIR, try not to do eccentric and don't do resistive exercise. That includes the trunk, the arms, the legs, as well as the head and neck. But always get them moving, get them exercising every day. If they have fair strength, get them upright. If they have less than fair strength, do active assistive and or concentric exercise. I'm not going to go into too much about our recommendations for exercise. Jackie will go into it significantly. What I do want to talk about is a little bit about one study about perceived fatigue. They looked at patients, and in all the patients, type 1, type 2, type 3, all these patients have fatigue. Whether it be fatigue from walking, 1 minute after the next minute, after the next minute, their time decreased, but also the children who are non-sitters, the children who are sitters, perceive fatigue. So you want to monitor that fatigue. And in this study, they look at the PEDS QLM or the MFS or the FSS. They monitor the amount of fatigue. You can certainly see that these children in your goal setting have fatigue, but you can also monitor how frequent are they sitting, how frequent are they standing, for how long, and what is their response. Again, where are we going? The natural history is changing really quickly, really quickly. 3 years ago, I couldn't perceive that I would be here talking and seeing some children who are, I would think, would be non-sitters are now walking now. But they have still symptoms of SMA. They have contractures, they have weakness. There is active drug research right now, active drug treatment. You want to use prospective care. Really think about, again, when they were diagnosed, what is their age, when did they get treated? As these individuals survive longer, it's really important to look at management. And you guys are on the forefront of that management. You guys make those decisions, engage with that family, and that's all I have. Thank you for PNCR for inviting me, SMA Foundation, and families.
Thank you, Richard. So I'm extremely overwhelmed because there's about 30 questions in here. So this was an excellent topic, and thank you for submitting them. I'm going to definitely encourage you to come talk to us during the break. Any of the faculty here, we can help answer any of these questions that we don't get to. But one that I thought was a really good one, in your experience, when working with both OT and PT, how are responsibilities, evaluations, assessments divided between the two disciplines so that there's not a duplication of services while providing maximal care?
So in our clinic, we actually do the evaluations together, both OT, PT, and speech, and nutrition too as well. We talk about functional capacity, what are their equipment, and we do that all together. Where we break off a little bit is the OTs look at more upper extremity function, fine motor ADLs, their hand function in writing, their engagement in school. I look more in the mobility section, their ability to transfer, to be able to stand and walk, their standing position, their walking position, and their adaptive equipment. We try to commingle those two, including with the neurologist plan of care, to try to send the family off to be able to attend with those things with CCS. It's hard because we see these children maybe 2 to 3 times a year typically, and we make these recommendations. You guys in the therapist world, you guys probably see them weekly, monthly, maybe yearly too as well.
Maybe 1 or 2 more. There was some questions on what age to implement or begin some bracing, including AFOs, KAFOs, TLSOs. Are there age recommendations?
So I look at a couple of things. One, I explore their range of motion, see if they have a contracture. 2, I look at how strong are they. Do they have less than fair strength? If they have less than fair strength and they're not developing, then I put them into some type of brace for positioning and also for stretching. When I think about children who are standing and walking, I try to think about lightweight as I can. I think about position. It's important to try to get them in a appropriate position so I can put them in standing. More importantly is, are they transitioning to a higher level of function, or are they more static? And that sometimes leads me to much more stability, or much more of a position of lightweight, and be able to provide them with a little bit of stability, but ability to walk and transition.
And then last one, there's quite a few questions about this. Is there a role for alternative therapies that can be done as well as PT, including electrical stimulation, ultrasound, kinesiotaping?
Yes. There is a big role, but I would be cautious. We get a lot of recommendations. E-stim, I probably would not do in-stim. I would recommend that you have actually as a contraindication, especially because I don't know how much am I stimulating a maximal contraction of a muscle, and you may have over fatigue. I also would caution you on chiropractic. I think a lot of our families do that, but again, caution you on that because these children are hypotonic and have increased mobility of their joints and their spine. Some of our families do compression devices on their arms and legs and massage, and I certainly highly recommend that. Anything that can improve movement and improve feeling of a quiet state is important.
Great, thank you so much.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.